Welcome to the webinar on late-stage liver cancer. I am Farah Douglas, President and CEO of the Liver Health Foundation. As you may know, cancer is the second leading cause of death in the world, but survival rates are improving for many types of cancer thanks to improvements in cancer screening, treatment, and prevention. With the advancement in early detection and treatment of cancer since 1991, there has been a 33% decrease in cancer mortality rates, which translate to prevention of about 3.8 million deaths. However, and despite all progress, cancer remains the second leading cause of death in the US. Most of us know someone who has been diagnosed with cancer. It is still quite frightening to hear the words from the doctor saying, "You have cancer." During tonight's program, we will learn more about liver cancer and how innovations have changed the diagnosis and treatment of liver cancer. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and portions of Arizona and Northern California. In tonight's webinar, Dr. David Emagawa will offer a comprehensive review of liver cancer through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Saab, Dr. Brar, Dr. Ching, and Dr. Emagawa. During the roundtable discussion, our experts will talk about their own experiences in working with liver cancer patients and their research on this subject. If you have any questions, please use Q&A or chat functions and post your questions. Our experts will try to respond to all questions. Now, the disclaimer. Please remember information given by our experts is not a substitute for advice given by your own physician and healthcare provider. We do not endorse doctors, hospitals, medical centers, or treatment. This program has been made possible by an educational grant from AstraZeneca Pharmaceutical. We thank AstraZeneca for their support. I am honored to introduce Dr. David Emagawa, who has generously agreed to be the presenter for tonight's program. Dr. K. Emagawa, MD, PhD, is Suzanne Dykema Endowed Chair in Pancreatic Cancer, Chief Division of Hepatobiliary and Pancreatic Surgery, Professor of Clinical Surgery, Vice Chairman for Academic Affairs, Department of Surgery, University of California, Irvine. Dr. Emagawa's clinical focus is the treatment of liver, pancreas, bile duct, and gallbladder cancer. He's also an expert in the prevention of and the treatment of bile duct injuries during cholecystectomy. His research interests include topics relating to the treatment of liver, bile duct, and pancreatic cancers. He has been involved as principal or co-investigator in over 120 clinical trials. He has over 130 articles published in peer-reviewed journals and is the author of numerous book chapters and abstracts. Dr. Emagawa currently serves as an ad hoc reviewer for transplantation for Journal of Surgery, Annals of Surgery, Liver Transplantation, American Journal of Transplantation, HPB Surgery, and Archives of Surgery. Dr. Emagawa is a member of the Association for Academic Surgeons, the American Society of Transplant Surgeons, the American Hepato-Pancreatobiliary Association, the Pacific Coast Surgical Society, and a fellow of the American College of Surgeons. He is also actively involved in service to the community and presently participates as a member of the Liver Health Foundation's Medical Advisory Council and assists the Pancreatic Cancer Action Network, known as PCAN, with their yearly fundraiser. He also serves as Chief of Staff as Chief of Staff for UCI Medical Center from 2005 to 2007. Dr. Imagawa received a Lifetime Achievement Award in 2022 from Liver Health Foundation for his incredible compassionate treatment of liver patients. Dr. Imagawa, we are grateful to have you with us. Thank you for your support and participation. We are ready for your presentation.
Great. Thank you, Farah, for that wonderful introduction, and thank you, everybody, for joining. I'm going to, let's see if we can share my screen here, and we will talk with my talk, which will be on what's new in the treatment of advanced liver cancer. So, as Farah already alluded to, liver cancer is a major problem both in the United States and worldwide. It's the fastest rising death rate of all cancers, of all solid organ cancers in the world. And risk factors, as we well know, are hepatitis C, hepatitis B, alcoholic cirrhosis, and the new kid on the block, NASH or NAFLD, or I guess we don't really call it fatty liver disease anymore, but metabolic syndrome or along those lines and the complications resulting thereof. In terms of treatment of liver tumors, we've done extensive talks here already on early treatments, which would include surgical resections such as lobectomy, removal of segments of the liver, non-anatomic wedge resections, liver transplantation, which is a whole talk in of itself, radiofrequency ablation, where we electrocute tumors, microwave ablation, where we use microwave energy to kill tumors, radioembolization and alcohol ablation, to name a few others that are there. But what we really want to concentrate on today is the treatment of advanced liver disease. Most of these modalities we're talking about are potentially curative or potentially bridges for transplantation. The area of chemotherapy has exploded rapidly within the last 10 years. And we've learned a lot about targeted therapy for the treatment of hepatocellular carcinoma. We've been kind of one of the latecomers, but we've made significant advances looking at the different receptors located on livers and then locating liver cancers, and then trying to design or finding particular chemotherapy agents, such as the above mentioned ones, that bind to these receptors and can kill liver cancers. The earliest kid on the block, if you will, was sorafenib, and this is a very old study, but back in 2008, this became the first and only chemotherapy agent that was available for advanced stage liver cancer for almost 10 to 12 years. And the sad part was, despite the very significant increase in survival, as you can see in the yellow line, the actual increase over placebo was actually only 4 months. And so it was a big step forward, but a very minor step in the overall treatment of cancer. Subsequently, we've looked at things that have worked on T-cell receptors, or the most exciting things are the checkpoint inhibitors, which look at the programmed cell death receptors. And the pivotal study that really has changed chemotherapy and established a new standard was the use of atezolizumab, a PD-1 inhibitor, with bevacizumab, which is a vascular growth factor inhibitor, and this compared it to, again, what was the standard of care at the time, and to sorafenib. And as you can see, the blue line is survival, and significantly greater survival in the first initially published paper on this combination. And in the follow-up, again, continued significant advanced survival, with median survivals up to 19 months. So a significant increase in the ability of chemotherapy and immunotherapy agents to advanced survival in liver cancer. Subsequently, another follow-up study was the Himalaya trial, which looked at a combination of antibody against activated T cells in combination with a programmed cell death inhibitor. And again, significant improvements greater than seen in sorafenib with median survivals at 24 months of 40% and 36 months of 31%. So again, a significant step forward, but significantly lower than what we see for a lot of other cancers. So in the last couple of years, there have been a couple of really significant other impacts. We've had a number of chemotherapies that have come to the forefront, and listed here are all the chemotherapies that in 2002 were approved for the treatment of liver cancer. But more exciting are a couple of new modalities that have come to the block, and I'd like to spend the rest of the talk kind of describing and discussing two different modalities that we have for treatment of advanced liver cancer. You can see this is the Barcelona Clinic's liver staging and treatment, which was modified in 2022 and has significantly become more and more detailed versus what we used to have in the old days, where there were basically no other options. And this entire block down here of all of the new chemotherapy agents has come because of these advancements in systemic chemotherapy. What I'd like to talk about first is a process called irreversible electroporation. And this is an application of short pulse, high voltage DC current to cells and tumors. And what this does is it non-thermally disrupts the cell membrane and actually causes cell death in cancer cells. The initial studies were done with a product called NanoKnife, but there's now a new product that's come to the block, which is the Aleva system by Galvanize Therapeutics. And I'm going to just play a tidbit here about the product. I have no financial stake in this company, but we do use this at our institution.
The Galvanize Alea system delivers pulsed electric field, or PEF energy, to ablate soft tissue lesions. The Alea system delivers non-thermal electric energy to generate an electric field in the tissue, resulting in the death of cells within the treatment zone, likely through programmed cell death mechanisms. As cells die from PEF energy exposure, they release intracellular cytoplasm, proteins, and cell fragments. Galvanize Alea PEF energy uniquely preserves the extracellular matrix, including vessels, ducts, and nerves. This remnant scaffolding, comprised of collagen and elastin, may provide support for the immune system to clear the cellular debris.
And one of the more exciting but unproven components of this galvanized Alea system is that there have been more than a handful of reports that have surfaced talking about let's see, I got to get back to mine. Yep, there we go. A number of patients who have been treated with where single lesions have been treated, and other treatments have other lesions have subsequently disappeared. This is called the abscopal effect, but has also been, like I said, shown that maybe additional lesions will go away when you treat them with the allele system. But again, this has not been completely proven. The next kid on the block is Histotripsy, which is a company that's Histosonics, which has developed a non-invasive ultrasound that they've called the Edison device. And this uses ultrasound to create pulse sound waves to create bubble clouds that are then able to disrupt tissue in nanoseconds. It's non-invasive since it's put on the patient like an ultrasound, and this was recently approved by the FDA for the treatment of soft tissue tumors and particularly liver tumors. The procedure itself does not require any incisions or needles. The device is placed on the patient. The patient does need to be under general anesthesia to control bleeding. Tumors that can be treated effectively, typically in one session, but sometimes multiple sessions can be used. And the patients typically are discharged home either that afternoon or the next day. Again, here's the device. It's placed on the abdomen. It then transmits these ultrasonic pulses, causes these micro bubbles on the liver, and disruption of the tumor. And again, I'm going to show you a video that the company provides, but again, we do have this machine.
Non-invasive sonic beam therapy that uses the mechanical forces created by focused ultrasound waves transmitted through the body to destroy targeted liver tissue. As these waves converge at a known focal point, high pressure causes extremely small, naturally occurring gas bubbles to expand many times larger than surrounding cells through a phenomenon called acoustic cavitation. As the ultrasound waves converge on the targeted tissue, the rapid expansion and collapse of the microbubbles forms a bubble cloud, which imparts mechanical forces on the cells, resulting in instantaneous cell destruction and leaving behind any acellular lysate. Histotripsy's unique mechanism of action results in cellular and subcellular destruction that occurs only within the bubble cloud, enabling highly precise treatments and avoiding damage to non-targeted tissue. Also, research indicates that strong collagenous structures like vessels and ducts are resistant to damage from histotripsy levels that destroy liver and other soft tissues. Unlike conventional therapies, histotripsy destroys targeted tissue by mechanical forces only. Research indicates that this mechanical mechanism of action tends to preserve antigenic material. Rapid resorption of the acellular lysate through the body's lymphatic system means involution, a visible reduction in treated volume, can generally be observed to occur over weeks and months after treatment by standard imaging methods. Histosonics has applied the science of histotripsy to develop Edison, a pioneering platform for image-guided sonic beam therapy. Edison's user interface allows physicians to plan their histotripsy treatment and monitor it in real time via the onboard diagnostic ultrasound. The Edison system represents a novel, completely non-invasive sonic beam therapy that precisely destroys targeted liver tissue and has the potential to entirely transform the patient experience.
So, well, what are the data? And so there's actually, limited data because this is a device that's just recently come to market. But here's a CT scan showing a hepatocellular carcinoma, arterial enhancing. And basically, when the ultrasound is placed over this, then you see cavitation and a no longer tumor being there. Now, the surgeons may argue, well, why are you bothering to do this? This is in a left lateral segment. It's a very easy surgical resection. But at the same time, this is something that potentially can be done as an outpatient procedure. Again, if we look at this, here's a tumor here. Day one, there's a nice hypodensity where the tumor used to be, and then over time, the actually fills in and the hepatic parenchyma returns to normal, which is very much unlike what you see with radiofrequency ablation or microwave ablation, where these ablation zones actually remain over time and don't involute and fill in with normal tissue. The Hope for Liver trial, which is still ongoing, was a prospective multi-center single-arm trial. There were 23 subjects internationally, 21 subjects in the United States. So you can see that the experience is fairly small, 44 subjects, 30-day data with them divided mainly between primary liver cancers and then also metastatic liver cancers. The ability to treat using this ultrasonic device was very efficient, greater than 95% of the cases, 42 of 44 tumors in very, very carefully selected patients were technically treated successfully. The adverse events were quite low. There was one patient who had a pre-existing indwelling biliary stent who got a liver abscess. One patient who had pleuritic pain from irritation of the diaphragm. There was one grade 5 event in that there was hepatic failure in a patient who had over 20 metastatic liver tumors who died after the procedure 37 days after. To tell you how I guess, bullish the institutions are. Here are the institutions in Southern California that actively are using this machine. Providence Mission Hospital in Mission Viejo, Hoag Hospital, UCI, the Southern California Liver Center will have theirs next month, and Providence St. John's Hospital will have theirs in February 2025. I think at least 50 centers across the United States have gotten there. This may be a case of it could be too good to be true, but at the same point, everybody is very excited about this potential for treating advanced liver cancer patients. I'm going to end there. Again, liver transplantation, surgical resection still remains the gold standard for the treatment of primary liver cancer, but we've made significant progress in the treatment of advanced stage liver cancers through particularly chemotherapy, and the use of these newer modalities such as IRE with pulsed electrical fields or histotripsy remain to be determined, but are being rapidly disseminated throughout the centers that do treat liver cancers. I'll end there and go to the roundtable, and we will all, the faculty will answer questions. Thank you for your attention.
Thank you, Dr. Imagawa. Very new information and hopeful information. Thank you so much. Now we will start the second half of the webinar, which is our roundtable. The goal of this roundtable is to talk more about the subject and also answer to the questions we have received. But remember also that you can post your questions on Q&A or chat function. So for this roundtable, it is my distinct honor to introduce Dr. Sami Saab, who really needs no introduction, especially to our patients. Sami Saab, MD, MPH, AGAF, FACG, FAASLD, is the Medical Director, Flagler Liver Institute, Medical Director, Adult Liver Transplant Program, Chief Transplant Hepatology, Head Outcomes Research in Hepatology, Professor of Medicine and Surgery, Adjunct Professor of Nursing, Honorary Professor, California North State University College of Medicine, Associate Editor for Liver Journal of Clinical Gastroenterology. Dr. Saab has been working with us in support of liver patients since 2014. He was the first member of the Liver Health Foundation's Medical Advisory Council and has been serving as the chair of our MAC, Medical Advisory Council, for many years. Dr. Saab is a sought-after speaker, has been named one of the best doctors in America, and has received the Distinguished Achievement Award from his Division of Digestive Diseases. He has published over 300 peer-reviewed manuscripts and has authored many book chapters, editorials, abstracts, and poster presentations. Dr. Saab is on the editorial board of more than a dozen journals and is currently the liver section editor for the Journal of Clinical Gastroenterology. Dr. Saab, I know you are having another program coming up soon. We really appreciate you joining us. Thank you.
Thank you, Farah.
Thank you. I am pleased to introduce Dr. Gagandeep Brar. Dr. Gagandeep Brar is Assistant Clinical Professor, Department of Medical Oncology and Therapeutic Research, GI Medical Oncologist, City of Hope, Duarte. Dr. Brar earned her medical degree at Ross University School of Medicine in Dominica, West Indies. She continued her training with a residency at Rochester Regional Health in Rochester, New York, and fellowship at Georgetown University Medical Center in Washington, D.C., and the National Cancer Institute in Bethesda, Maryland. She identifies with City of Hope's mission of providing excellent patient care with access to clinical trials and new and innovative treatments. Prior to joining City of Hope, she worked as Weill Cornell Medicine New York Presbyterian in New York, New York. Dr. Brar, welcome to Liver Cancer webinar and to Liver Health Foundation. Thank you for your participation.
Thank you so much for having me.
Thank you. I'm pleased, it's my pleasure to introduce another new friend of Liver Health Foundation, Dr. Jason Ching. Dr. Ching, MD, PhD, is Assistant Professor, UCLA Radiology Sciences, Interventional Radiology Section, David Geffen School of Medicine at UCLA, Jensen Comprehensive Cancer Center. Dr. Ching received his bachelor's degree in biomedical engineering with a minor in mathematics from Johns Hopkins University. After college, he was awarded a Fulbright grant to conduct research in Hanover, Germany. He then entered the medical scientist training program at the University of Wisconsin-Madison, where he obtained his MD and PhD in biomedical engineering degree with a certificate in clinical investigation. He did his internship at Gunderson Hospital System in La Crosse, Wisconsin, and returned to Los Angeles to complete his diagnosis education. Sorry, I lost my place. His clinical focus is on the diagnostic, imaging, and treatment of solid tumors with minimally invasive techniques. He divides his time between vascular interventional procedures and cross-sectional interventional procedures, with a focus on interventional oncology, vascular disease, and liver interventions. He also runs an active NIH-funded translational research laboratory focused on bringing the latest cutting-edge technology to his clinical patient population. Dr. Ching, welcome. We're happy to have you with us and hope that in the future we continue our work with you.
Great, thank you. Thanks for having me.
Thank you. So over the past few days, I had received questions from the audience as well as those who couldn't be with us tonight. The questions have been sent to all of our doctors. To start the roundtable, I start one of the questions that was repeated many times, Dr. Imagawa, which was, what is the prevalence of liver cancer in various ethnic groups, such as Asian, Hispanics, Middle Easterns, Black, and others? Would you go ahead?
I'm happy to answer that, but I think maybe our hepatologists might be better suited. I mean, it's obviously it's not a disease of the United States as much as it is of sub-Saharan Africa and East Asia, but I think I'd defer to Dr. Saab for that.
Yeah. So thank you, David. So Farah, the question was the prevalence of liver cancer in different ethnic groups.
Yes, yes.
So it's a great question. It's not a matter of ethnic group, but a matter of causes of liver disease. So if you look at places like Asia, China, where they have a very large hepatitis B population, hepatitis B there, it's a very common cause of liver cancer. And so the prevalence, it could be like 3 to 5% per year. In the United States, where fatty liver is a huge problem, it's probably a little lower than that. So it all depends on the risk factor of liver cancer to know the prevalence. But in parts of the world like where hepatitis C is common, hepatitis C is a driving factor. So it's not a matter of ethnic, but it's a matter of the cause of liver disease. In the United States right now, probably the most important cause of liver cancer, like Dr. Imagawa mentioned, was probably fatty liver. And as you know, liver cancer doesn't occur in a vacuum. It occurs in a setting of very dirty soil. And so the most common cause is going to be fatty liver, NASH, hepatitis B, and hepatitis C. So when you think about liver cancer, you got to think about two things: liver cancer itself and what caused the cancer. What causes cirrhosis. Hepatitis B, C, or alcohol, the most frequent causes of cirrhosis. I hope that answers the question.
Right. The other question that have been asked, and I don't know which one of you will answer, the possibility of someone who has liver cancer and get a transplant, what's the possibility of them to develop another form of cancer? And does liver cancer, does it transfer to other forms of cancer like breast cancer, lymph cancer? Whoever wants to answer, please, welcome.
So I can take a stab at that too, since it involves hepatology transplant. But there's a very strict selection in terms of who gets transferred liver cancer, and what the idea is to prevent recurrent cancer after transplant. I got to tell you, in the past several years, I've not seen one patient develop recurrent liver cancer because patients are very properly screened. After transplant, people are immunosuppressive drugs, and unfortunately, it does put them at risk of other cancers, the most common one being skin cancers. Nevertheless, the idea is that after transplantation, people are able to live longer and better lives than without a transplantation for liver cancer. But recurrence rates are very low today.
Anybody else wants to add something?
Yeah, I think like 20, 30 years ago, when they were still trying to figure out who were the best candidates for a liver transplant, they were actually trying to identify what potential biomarkers would predict whether someone would be a good transplant candidate. And one thing they did find was histopathology, which is just histopathologic grade. So how aggressive the cancer would be when you do a biopsy or a surgical resection. And in those cases, patients who had, for example, like a poorly differentiated HCC and got a transplant, they would have a higher risk for recurrence afterwards. And I think these days in our tumor board, at least, we talk about all of these factors. And so, as Dr. Saad mentioned, we're very careful about who gets it. And so for those reasons, better surveillance and better characterization of the risk factors, the risk for recurrence is much lower than it was 20 years ago.
And I think another reason why too is like Dr. Imagawa said today, we have such more effective medication before transplantation, and these have been godsend. And the challenge we have now is, do people really need a transplant for liver cancer? Because as Dr. Imagawa said, we have such effective therapy. So that's a dilemma we face on a daily basis. Should we transplant someone or not after the cancer's been treated?
Dr. Imagawa, there is a question for you. I sent that to you. Do you see that in your chat? Or
Yes.
Okay.
Great question. So we're still learning about this, but
The
basically,
others don't know. Would you please
sorry.
read the question?
The question is in regard to histotripsy, where do the cancer cells go? Dissolved by the lymphatic system over the following weeks? And how do you prevent gastric carcinomatosis with this procedure? So what happens when the ultrasound is pushed over there? It basically disrupts the cells. So the cells basically explode. And so the key is to put this ultrasound, and the ultrasound device is agnostic. So it'll destroy any cell that's there. So the key is to three-dimensionally make sure that all you are destroying are the cancer cells and a small margin of normal cells around the cancer. So the cancer cells they explode, they're not viable. And the thought process is that those remaining cell fragments can elicit an immune response that allows the body to fend off additional cancer. So no cancer cell dissemination occurs during the procedure, only bits and pieces that are not large enough to cause a cancer downstream. I hope that answers the question.
Anybody else wants to jump in on these questions?
Yeah, I think that histostripsy is something we've been studying for a while. And one problem with liver cancers is a lot of them are hiding from the immune system. Like if you like injected a little cancer inside you and me, like healthy individuals, then our immune system would pick them off. And the problem with cancer is that it's hiding from the immune system. So one of the advantages of histotripsy, like Dr. Imagawa mentioned, was that it does kind of make these cells explode, and cells that were previously hiding from the immune system are now, when they explode, parts of it are being released, being exposed, so the immune system can actually identify them. So it's kind of like red flagging them for processing. And the idea is that your immune system can recognize it, process it, and then identify different antigens in other parts of the liver. And so I would say there's potentially two mechanisms. One is the direct debulking, and two is the antigen sensitization.
Dr. Brower, you want to add something?
Yeah, we don't do histotripsy at City of Hope, so I'm also learning.
Wonderful.
And I would say I have just maybe one question just to kind of add to this is, does depth of invasion kind of change, how you utilize histotripsy, or I guess size of tumor?
Yeah, great question. So there are significant limitations to what you can do. The current device can only send an ultrasound pulse 12 centimeters. So anything that's deep in the parenchyma, you have to be able to reach the back end of the tumor. So in a well-built individual with a lesion deep in segment 5 or 6, you're not going to be able to hit it. Additionally, the ribs get in the way, so you can't go through ribs to direct the pulse downwards. So the newer machines will have deeper penetration, and I think that there will be ways to manipulate things so you don't have ribs in the way. It's a learning process right now. So yes, there's significantly a segment 3 left lateral segment 4B, really easy to hit, but the right lobe liver lesions are very, very difficult to get to with because of the depth of penetration. So yeah, wonderful question.
We have a general question asking, could you share the best screening strategies? Who should be screened and when and how?
I can take a stab at that. So it's a great question. So if you have someone you believe at high risk, and that's someone who has cirrhosis or has hepatitis B after the age of 50, the current recommendation or standard of care is abdominal ultrasound and a blitz called AP every 6 months. If either of those become abnormal, and then you go to the next assessment, which would be a CT or MRI. The challenge is identifying who's at risk, because people with cirrhosis are not wearing badges saying, I've got cirrhosis, screen me. So it's very important that we identify who's at risk for cirrhosis, risk for liver cancer, and screen them appropriately.
And somebody also asked, their mother died of primary liver cancer. She was active, she was walking a lot and eating relatively good, according to her daughters, but she got primary liver cancer and there was no history of cancer in the family. So they are still, the mother had unfortunately passed away, but they're still kind of confused as why their mother got liver cancer. There was no reason, according to everything that they have read, for her to have liver cancer. Does anybody want to talk about that? Give this family some sort of peace of mind about their mother who has unfortunately passed away.
Well, I can take a stab again. It's Sami Saab. So unfortunately, liver cancer doesn't occur by itself. Generally, there's something that precipitated it. And again, the most common causes could be hepatitis C, hepatitis B, fatty liver, could be alcohol liver disease, could be autoimmune liver disease. But generally, with primary liver cancer occurs in a setting of damaged liver. There are rare cases of liver cancer forming without underlying liver problem, and that could be from a benign tumor called adenoma that's converted to liver cancer. That's very uncommon, very rare, but it can happen. But generally, it occurs in a setting because something caused liver injury, and that liver injury resulted in liver cancer. Thank you, Farah.
Thank you. Okay, so I'm going to jump into the next question, and that's interesting to me too. It says, I read a study that revealed Generation X and millennials face a significantly higher risk of developing 17 types of cancer compared to older generation. Is that true? Our younger generation are living in a bad diet, bad lifestyle?
I can probably take a little bit of this. So I think even in our own clinics, you know, we are seeing some trends probably in the last few years, where patients, you know, under 50, let's say, are coming through our doors with a variety of different cancers, including liver, GI cancers. You know, I think as we're diving deeply into why do young people, you know, develop a cancer that in the recent time used to be for older people, we're learning quickly that there's not one answer, I would say. So, you know, some of the studies that have come through, or some of the hypotheses, are diet related. Some of it is also going into microbiome research, where you're looking at, you know, how does our gut flora change based on different variables through our, you know, eating habits, our environmental factors, you know, anything really. And does that is there a causative link to the development of these cancers? I think that the simple answer is we don't have one answer to define that. But I think a lot of us are working that we see this, but we're also trying to very quickly understand it better.
I'm going to be less politically correct than Dr. Brar. The American Cancer Society recently published data showing that there's an increased risk of cancer in pediatric patients, and the number one causative factor was obesity. We have an obesity epidemic, and the idea that it's okay to be obese is not okay. And I'm sorry, I get in trouble every week for telling people to lose weight, but obesity causes cancer. There's an association. There is no question. It is not healthy, no matter what anybody says.
So that's really something that always bothers me, because I think we are changing even the terminology, but we are concerned now. We cannot say fatty liver disease because it has the word fat in it, which is unfortunate. But I agree in a way with Dr. Imagawa, because it's unfortunate. Dr. Imagawa, you received another direct questions to you that I sent it to you. If you can visit that, and then we can, after that, move to the next question.
So the question is, how do I know if I'm eligible for histotripsy treatment? Really, the best way is to reach out to that list of institutions that are actively doing histotripsy. And I'm going to apologize if I left off any places that have it, but or are going to have it soon. But, you know, again, Mission, Hoag, UCI, I think, or at least currently have them active. I think other places will be active. Any of their 800 numbers will get you into, you know, this to be looked at. So it's not a simple yes or no. So if you really would like I said, those programs are actively looking and screening patients. And it's at the point now where there's actually basically a weekly national tumor board of all of the institutions that are using this machine to look at eligibility.
Another question we received, does anybody else want to answer this question, or should I move to the next one? Okay. The other question was that a woman wrote that her grandmother is in palliative care for her liver cancer. Her doctor now is talking about low dose radiology. She said, even though she's talked to the doctor, they don't really understand what it does for the patient. Low dose radiology, does it make them have less pain? Does it make them live longer? So any of you that would want to attack that question will be great.
Well, I'm a radiologist, but I wonder if they're talking about radiation, like radiation therapy, like external beam radiation. So that would be in the spectrum of radiation oncology, which is, you know, not part of radiology at the moment. Yeah, so I guess I would just turn it back and ask for clarification. If they are talking about external beam radiation, I don't know if anyone else wants to take this for pain management, but they do. It's mostly a palliative thing for metastatic disease, especially for the bone. I don't know if anyone else wants to pitch in. I'm not a radiation oncologist.
So that's basically to keep the patient more comfortable as in the last stage of their lives.
That's right. Yeah, I think typically if there's metastatic disease to the bone, which is a very common place for liver cancer to go, and it's causing pain, yeah, they can get external beam radiation, and that does take some of the pain away, but it does not make them live longer.
The other question was, what is therapeutic treatment for cancer, liver cancer? If you would please answer.
Yeah, I can take a stab at this one as well. I know we talked about some of the treatments for early stage liver cancers, and that's something that I do is we do thermal ablations. Thermal ablations as it's a minimally invasive procedure, involves using a combination of ultrasound and CT to guide a needle through the skin, into the liver, into the tumor, and energy typically comes out of the tip of that needle, and it essentially cooks the tumor. And there have been fantastic responses to patients who undergo this procedure, and we're able to either keep people on the transplant list, or in a lot of cases, they have almost essentially a curative result. So that's one of the procedures that we can do. The other procedures that we do are intravascular procedures. And so a lot of the early and even intermediate stage liver cancers, we can identify the exact blood vessels supplying the tumor, and we can administer chemotherapy or internal beam radiation therapy into these blood vessels to precisely hit that tumor. And so most of these procedures are used in early stage liver cancer, so patients who are still within transplant criteria, but certainly for patients with, for example, vascular invasion, we have pretty good data showing that. When you in the advanced stage setting, radioembolization with Y90 beads, for example, has pretty good data. So that's the treatment where we can find those blood vessels, drop some radioactive beads in there, and there's been good improvements in overall survival from recent data. So that is something we do for the advanced stage. And one thing to just iterate that these are all minimally invasive procedures. These are essentially outpatient procedures. So you would go in, get the procedure. In some cases, you'd just get moderate sedation, and you'd be able to recover and go home the same day. So a lot of patients like these treatment options.
And
Dr. Broad?
yeah, and I can also touch on general therapeutics, I would say. So Dr. Imagawa sort of nicely highlighted what our general treatment options are. Usually patients are coming to us if, for example, they're not a transplant candidate, their cancer has extended outside of the liver, or perhaps, liver-directed therapies are not possible for one reason or the other. I will say that the field of what I do has really come a long way since, 2007, when we had one drug and now we have, 10 drugs. The way that I typically talk about these drugs is that we have sort of two main buckets of treatments. So liver cancer is a very immunogenic type of cancer, and it's also a very vascular cancer. So one of our buckets is immunotherapy based, and the other bucket is targeted treatment, or we're trying to, try to starve the blood supply to the tumor to then help control the tumor long term. And so we have a variety of combinations or single agents for patients. It really depends a lot on also the underlying function of the liver itself, because ultimately we want to control the cancer, but we don't want the liver to get into any worse trouble. So, a lot of our treatments are based on something called Child-Pugh score, which is just kind of a way that we can see what the underlying health of the liver is.
Thank you. Question is people genetic, if someone is genetically predisposed, sorry, to developing liver cancer, can they develop other forms of cancer, such as breast cancer? Is the cancer cell, I guess the question is, does it travel? We have heard from some patients that said, when cancer discovers you, it will never leave you. If you treat breast cancer, few years later, it comes up somewhere else. And it's just like it stays in your body, whether you know it or not. Is that a true understanding? That you can never be really cancer-free. It's always in you, but it's...
No, so this is Sammy. From a hepatology point of view, the genetics of liver cancer are very different from breast cancer, stomach cancer. So it's a whole different cancer. And like the advances that Imagawa described, if they're cancer free, I mean they're cancer free, and they're not predisposed to other cancers. And I'm sure there's exceptions, but liver cancer is pretty unique in that sense. Doesn't make you genetically predisposed to other cancers.
And one of other question is, what is the most effective way of early detection of liver cancer? What is best
Yeah,
way?
so great questions. That goes back to an earlier comment about how to screen. Like everything else in life, the earlier you diagnose something, the faster you can intervene, and then the better the outcome. So we want to identify people early by screening by ultrasounds and blood tests called AFP.
All right, I don't have any more questions. I'm wondering if any of you wants to add a few things that people didn't ask. One of the things maybe will be chemotherapy. People are very afraid of chemotherapy because of what it does to the bones and to the body itself. They lose their hair, their bones are falling apart. Is there any safer way for chemotherapy? I know that you're now directly can inject to the tumor, which is huge. But most people still go through chemotherapy too. Is that right?
So for liver cancer and HCC specifically, coming back to those two buckets, we don't actually use chemo. So it's, targeted therapy or immunotherapy. And generally speaking, you don't get the same side effects as you would with sort of standard chemo. So I would say most of my patients have their hair. There are other types of, side effects that can occur, but very different. So I would say if there's a fear of chemo, that should be distinguished from, fear of treatment. So I hope that kind of answers that.
Dr. Cheng, you want to say something about this too?
Yeah, I think you kind of alluded to already. We deliver chemo directly into the blood vessel. And so, for example, the doxorubicin that we use for transarterial chemoembolization, it stays in it. I deliver it right into the blood vessel, into the tumor, and it just stays there, actually. So it doesn't go anywhere else in the body. It doesn't go to like the brain or like the chest or the legs. It just stays inside the tumor. So usually people don't feel anything after it. So so yeah, I guess that's more for like the early stage. Even in the advanced stage though, again, the tumors are very hypervascular, as someone alluded to before. So sometimes if you just drop it even like a little bit further out in the blood vessel, the tumor will actually suck up the chemotherapy or like the radioembolization beads. And so this particular disease, we're just very, I guess, not lucky, but fortunate, but like it just happens that these are hypervascular tumors and that they can take up the therapy and keep it away from the rest of the body.
Dr. Imagawa, you want to add anything for the final part of our webinar?
No, I'd like to thank everybody for participating. It's always wonderful to do these, and it's always great to be surrounded by such educated and well-known peers. I think it's a learning event for all of us, which is always very helpful. But again, and like I said, is if people are interested in these, you just, reach out to any of the major programs, because I think everybody here is very happy to help out. And obviously they are happy to be here and spend their time to help educate and help push things forward. I think for the physicians here, this is it's more than just a job. It's a lifetime calling and commitment.
Dr. Saab, do you want to say something before?
Yeah, always a lot of fun, and I want to commend Dr. Imagawa for taking such a complicated subject and to make it so simple for everybody to understand, including the physicians. And I learned a lot from him today, and I can't wait to my colleagues about some newer modalities that I wasn't aware of to treat liver cancer. Thank you.
Thank you. I want to make sure that our audience know that our presenters are here as volunteer physicians. They care deeply about liver patients, about you. They use their own personal and family time and share their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. My personal heartfelt appreciation, of course, to all of our guests tonight for their kindness and compassion. Dr. Imagawa, thank you so much for your presentation. It was wonderful, full of new information, and I felt it was very hopeful for future for liver patients, liver cancer patients. Thank you, Dr. Saab. Liver Health Foundation is grateful for your support and guidance. We appreciate your continued support of Liver Health Foundation. Thank you, Dr. Ching, for accepting our invitation and participating in this webinar. You added very crucial information to this webinar. And Dr. Brar, thank you. Thank you for sharing your experience and insights with our patients, and we hope to continue working with you and Dr. Ching as we do our all of our webinars. I want to thank our sponsor, AstraZeneca Pharmaceuticals, and a couple of notices. September 21st is Liver Health Foundation's annual Walk for Your Liver, Los Angeles in Santa Monica. This is a family-oriented, very community-friendly walk. Everybody is welcome. Kids are welcome. We have face painting. We serve breakfast, simple breakfast, but there are balloon music, and most importantly, you support liver patients. Registration and participation are free. Please visit our website to register to walk with us. Liver Health Foundation will host a webinar on autoimmune hepatitis on September 26th from 5:30 to 6:30 p.m. Pacific time. Please join us. This autoimmune hepatitis is a rare disease. We have a wonderful guest who is living with autoimmune hepatitis. She will share her story with everybody too. And the best party of the year, Salute to Excellence in Healthcare, is planned for October 25th in Los Angeles. This is our annual gala to celebrate the best of the best in liver care. During the event, we honor hepatologists, liver surgeons, nurses, medical centers, patients, and more. It is our way to say thank you to everyone who is working so hard to save liver patients' lives. Please check our website and join us for our Salute to Excellence in Healthcare. Liver Health Foundation is on all social media sites. We announce our events on social media, so please visit us and like us. So at the end, thank you so much for joining us this evening for this important webinar. We hope to see you at the Walk for Your Liver Los Angeles on September 21st and autoimmune hepatitis on September 26th. Once again, I want to thank all of our doctors who use their own time to help us to share this valuable information with the patient. Be well, take care. Thank you, everyone, and good night.